An 82-year-old gentleman presents with progressive dementia that he has had for the previous 10 years. He previously manifested great anxiety about his various medical problems and his inability to remember counseling and other information provided to him by numerous medical specialists. As his dementia progressed, he became much less concerned about his health. When he was hospitalized for congestive heart failure, he and his family agreed to comfort measures only, and an advance directive was made apparent in his medical record. He returned home with hospice services, and there was a great reduction in caregiver stress. He died peacefully at home with his family at his bedside. Dr. Llewellyn, what strategies have you found work best when discussing advance directives with patients and families?
It's really important, I feel, to involve the patient with the decision making to their capacity. Just because they have a diagnosis of dementia does not indicate that they cannot be involved in their plan of care. It's also really helpful to ask the family what they feel like their loved one would want when they were able to make these decisions, when they're of sound mind. What do they think that that their loved one would have requested them to act on, thinking about their current situation, thinking about their current quality of life. And it's really important to address these advance directives at least annually on a routine history and physical, but then also it's really important to address it with any change in level of care. So if you're transitioning from the community setting to the hospital setting, and then also when they transfer then to a rehab facility or assisted living facility, and then anytime there's a significant decline or change in status.
Dr. Kearns, is denial among family members of patients with dementia common, and how might the treatment team best approach dealing with the family's denial?
Actually, denial is a common process in family caregivers. There's a number of reasons this might occur. It may simply be that the caregiver is overwhelmed by the stresses of being in the caregiver role, also by the stress and the pain of seeing their loved one in a diminished capacity. So very often, it's important to address the underlying stress and emotion associated with the denial and really provide a means of helping and supporting the caregiver. Another reason might be respect for example, a patriarch, and seeing perhaps an aged father who's always been the rock for the family, seeing that person struggle and not wanting to undermine what might be perceived as the respect and interfere with his independence and fear that that might be disrespectful. So caregivers may allow an individual to be more independent for a longer period of time when they're really not able to do that.
Can you describe what types of caregiver burden that you see and suggestions you give to families to prevent stress?
Well, the most common burdens we see for caregivers have to do with isolation, being isolated from their own support system as they focus on their role as caregiver, and that really can become overwhelming and become the center of their focus, to the point where their own health habits sort of are set aside, and that can have a detrimental effect in terms of a lack of exercise, not eating the right foods, certainly depression, sadness from the social isolation. That can result anxiety as well. Feelings of frustration and anger are common, and that's often followed by guilt. Because if you think about it, here is someone who has put forth all of their resources to help the family member or the patient, and now they find themselves conflicted because they're angry at their inability to help in the way they would like, or frustrated by the inability of the patient to respond. In terms of identifying the needs of the caregivers and addressing those needs, it's very important for caregivers to be in touch with the resources that are available in their community. And also, of course, to take care of their own health needs, making sure that they're eating right, getting enough sleep, getting enough exercise. We often see caregivers who neglect their own medical care. They don't keep up with appointments because, again, their role as caregiver takes over their life. Looking for support groups that are often available is another important step for caring for the caregiver.
Chaplain Crane, please tell us how you would plan for bereavement care for this family.
The most important thing I would do, and I would hope that any chaplain would do, is really, as they've got to begin to know the family, that they're doing a spiritual assessment in almost every time they gathered with them, so that as they're finding out what has brought meaning to the patient and to the family, they can be working with them and doing sort of preparatory bereavement as they're also doing celebratory work with the family. I think with the dementia aspect, there are pieces that they're already losing of their loved one long before the actual end of life happens, the actual death occurs. And so I would want them to be doing some memory work with the patient and with themselves prior to the actual death. And memory work may be re-looking at what things that patient most liked in life and then create it while they're there. For example, if a trip to the beach was wonderful, they can recreate that and have the veteran be part, or the patient be part of that. And so then when they do the bereavement, they have the old memories and the newly created memories, and all of that will be part of their care. I would also work really closely with bridging to the hospice care that they get, and part of hospice has a 13-month bereavement program afterwards, and so make sure that they were tied in with that and the family could begin that work prior to the death again, and then do every 3 months making sure that they're being checked in on, do memorial service and really encourage them to be part of that. And looking at the rites and rituals from their community, from their faith tradition, and certainly from the patients. And so that that can be an active part of their bereavement and therefore their healing, which is really the gift you want to give them in preparing them for bereavement and working with them afterwards.
An 84-year-old gentleman lived alone in a trailer that he filled with numerous possessions, to the point that he barely had any living space. On a rainy evening, while asleep, he fell on the ground outside, his front entrance fracturing his elbow. But he was unable to enter his trailer because of all of the clutter. He remained on the ground for over 24 hours until a neighbor noticed him and called for help. He was hospitalized for exposure and received surgery for his fracture. In the recovery period, he experienced delirium for several days. The treatment team diagnosed him with early dementia, and the patient was adamant about returning home with the help of friends. A treatment team meeting was held, and the patient was able to receive legal assistance in appointing a durable power of attorney. He was then placed in an assisted living facility. Dr. Llewellyn, how can the treatment team be assured of a safe discharge environment?
Well, it can often be very challenging to evaluate a patient's home setting and their support system in the community, especially when the patient's currently in the acute care setting, and even at times when they're in the post-acute care setting. It's really good to have concrete information, and we often have to rely on either the patient's family members, neighbors or friends, or even their caregivers in the community, whether they have had their community physician has been involved or they had some type of home visit program. So reaching out to whoever might be able to give us that information can be helpful. And within the post-acute care setting or in the community setting, you can involve other team members like home health care providers that can go in and do a safety evaluation to look at the patient's home environment and really establish if it's safe for them to go home, and if they do go home, what needs they might need. It's also always important in this situation to evaluate the patient's advanced directives. And we really focus on that at any transition. In this particular patient, this would be a good opportunity to do that. And the forms that we're currently using within all states is referred to as either a POST, a POLST, or a MOLST. And it stands for Physician Order for Life-Sustaining Treatment. And the primary difference between the POLST is, and an advanced directive, is that it doesn't necessarily appoint a health care representative, and they're typically used more in acute situations or settings. But it really does provide a direction for the current treatment that the patient would wish for. And it really just allows care providers to know what type of intervention that patient would wish for. There are 4 sections or 5 sections within some POST or POLST or most. They'll all vary a little bit, but generally your first section is going to indicate whether the patient would want resuscitation or to not attempt resuscitation. The second section focuses more on the medical intervention that would be conducted, and that would include 3 different categories, including comfort, limited, and full. The comfort really focuses on maintaining comfort at all costs and not doing any type of invasive procedures, whereas the limited focus could indicate hospitalization, but you would avoid the intensive care setting or invasive procedures. And then full treatment would just indicate that they would want anything done that was indicated. And then the next section would be whether or not they would want antibiotics. And that's just a simple yes or no. And then following that would be indications for artificial nutrition, whether it's IV fluids or tube feeding. And then finally is a section for the people that are completing the form to sign. So that would include the physician that would be signing the form, because it is a physician order, so it requires that signature, the family member or healthcare surrogate that's assisting with filling out the form, and then finally the care provider that's helping them fill out the form as well.
Dr. Kearns, with the information you have from this case, do you think this patient has decision-making capacity?
Well, just knowing what I know from the case, we have a situation where someone was living alone and not really able to maintain their living environment in a safe manner. This person was hoarding belongings to the point where it became unsafe for them to move around their own dwelling, and that resulted in a fall. So that's one piece of information right there that indicates some impaired judgment. And it may be necessary to engage in a little bit more thorough evaluation to determine whether or not the individual can make a choice, whether they have the ability to make a determination between 2 alternatives, and then really to understand the consequences of their decision and be able to make a rational choice and manipulate that information as the situation changes. But in this case, it appears that this individual lived in an unsafe environment that he sort of lost control of, was clearly isolated from family and friends because he he laid outside of his home for 24 hours or more without any contact from anyone else. So it really seems to be someone who's very vulnerable and has some impaired decision-making capabilities.
Can you describe the process involved in determining capacity?
Yes, I mean, as I mentioned before, determining whether or not the individual has the ability to make a choice and make an informed decision. Very often, if there's a choice to be made about medical care, a physician may ask the person to repeat their understanding of what's been said so that the medical provider has an idea of whether or not the patient understands what they're choosing between. And then also what the consequences of that choice might be. It's also important to determine whether or not the individual is able to tie their own values to the decision being made.
And can you describe when adult protective services should be consulted?
Well, there are a number of circumstances when adult protective services could be consulted or should be consulted. One certainly is if there's a situation where we're concerned that an individual is being abused, if there's some elder abuse going on. That could be physical, emotional, it could be financial also. We see that unfortunately. Whether a person is living in an unsafe environment. In this case, we have somebody who didn't have family or friends or any real social support available to be aware that there was a safety issue. And that's a very dangerous situation because, you know, had this man not fallen, he would, of course, continue to live in that circumstance until perhaps something more serious occurred.